Hello, everybody. This is Dave Crawford, Director of Training Development for CASAC Trinity. Today's training topic, treatment as an evidence-based practice, stages of change, stages of treatment, stages of group, how it all goes together and based on the client's motivation and ways that work if we work it. So what does that all mean? Well, that's what the training is about today. We're going to unpack that fully, but basically it is evidence-based practice. I think all of us are pretty much aware that that means what's founded in the research, what's founded in best practices, what we have seen as a professional that kind of is effective. And because that's at the end of the day, we want to be effective. Today's training, though, however, is about that stuff, but also about the difference between a treatment model and a treatment approach. Because every outpatient I've worked at, they're all laid out basically the same. And the core and kind of gold standard of treatment is the Transtheoretical model. And that's what our state groups are based off. That's what our interventions are based off. And I mean, there's so much more. We all know that DBT, CBT, motivational interviewing, but this is a motivational theory too, but it is different. Trauma informed, person centered, like all these different things we take and we put it together. Later on in the slide, I'm going to say it, so I'm already getting ahead of myself, but I look at it kind of like the model is like our toolbox, and then all that other stuff is kind of the tools we have within it. So I hope that you enjoy. I think it's got a lot of good information. First thing I do is have a video by Marsha Linhan.
I'm a big believer in evidence-based treatment. In other words, I'm a believer in having treatments that have been found in scientific investigations to actually be effective. There are an enormous number of treatments out there that don't have any evidence, and there are an enormous number of problems that we don't have treatments for. The behavior therapist point of view is that treatments need to be validated. You need to have data that they in fact work, okay? And the American Psychological Association would say that a treatment has to be replicated at least 3 times before you can call it an evidence-based treatment. It's very easy to get one study that shows something works, but then never get it replicated. In other words, other people try to show that it works again, but it doesn't work in the next study. And we have loads of therapies like that. The problem with psychological interventions is that historically, they have been viewed as more art than science. Medicine at one point was also viewed as more art than science. And medicine went from art to science. And now there's all sorts of federal controls on what you can do, and that medications cannot be sold if they haven't been determined already to be evidence-based and not harmful. The problem in psychological interventions is that although we now have a lot of treatments that are evidence-based, there's no requirement that I know of, hardly anywhere except a couple of states, that people be provided evidence-based. In other words, the FDA doesn't let drugs go out that aren't evidence-based, but there's no one saying this psychotherapy can't go out because there's no evidence for it. And that being said, evidence-based treatments are often not being taught in graduate schools. Evidence-based psychological treatments are ordinarily not taught in psychiatry programs. There's a requirement in medical school that you can't teach residents and medical students to use medications and procedures that have no evidence. Here's the problem. Many people grew up and got trained before there was a lot of evidence-based treatments. The behavioral treatments were criticized for years as only treating what was called symptoms. I don't think anybody would say that now. The data is too overwhelming for anyone to say it now. But the facts of the matter are, you have thousands of people trained in non-evidence-based treatments. So it's in their interest to keep up the battle that research is not that important, because they could lose their jobs or not be able to practice. So there's a huge incentive, but this is This is not unique to psychological interventions. It happened in medicine too. So it's just a battle that we haven't won yet, to where insurance companies require evidence-based treatments. The government requires it. States require it. We have some states that are requiring people to provide evidence-based treatments. Some places where they'll pay you more if you do it. We just haven't won this battle yet.
So that's it in a nutshell. And then when I was putting this training together, I like that very much, that video, because she kind of says exactly the point I'm trying to make today. If you're not aware who Marsha Linehan is, she is the creator of DBT therapy. She is the founder. She's definitely worth listening to. I know that if you haven't heard of her directly, we've all heard of DBT, and she is the one that kind of put that all together as a treatment approach for us. And I think her emphasis on evidence-based is very important. And I think we get lost, and myself included. And that's why I kind of hoping to like bring us all back a little bit. I think that we hear these things from colleagues, we have conversation, and it's all good stuff. Like, that's the creative, beautiful juices we want to see flowing. And then we take trainings and we'd be like, hey, that's interesting. I like that. So I want to learn more. But I think what we failed to do, and even myself in practice, is make sure that interventions match the person and the problem and the population. You know, so like we might do a training that was designed and tested on females in a residential program. That doesn't mean it's universal. That means that the evidence base suggested that in that population, it was effective. And again, like Marsha said, that doesn't even mean it can be replicated. You know what I mean? So much, even in the science, while we're still empirically supported, like the true lab conditions aren't really utilized anymore, or scientific methods. And that's not bad. I think the real life observation and kind of those quasi experiments is like more appropriate and more realistic. I mean, if we're having completely artificial experiment, like it's artificial by nature. So I definitely think the new way is better, but I think that we need to be paying attention as practitioners to what we're utilizing. So again, my hopes is to like just remind everybody what the core is of this model, what the standard is. You know, I recently put together the application for CASA to do the CASAC program, the 350 hours of teaching internally. And when doing it, so like I have felt this way, and again, I get off track. I mean, I went down, I find a new approach or a new theory and it interests me, and I'm going to use that in my practice, like pieces of it though, but even still, I'm not going to use it rigidly. My core has always kind of been this, and it was what I was taught. And as I was putting the CASAC application together, I realized that even CASAC's or OASIS requirement to teach the 350 class, 80% is still based on what I'm teaching today. The 20% was that other stuff, like, hey, these are the add-ins, but like the core is still this, and this is what the evidence shows is most effective. And again, like I said, every treatment agency I've ever worked up, the stages of group are built on it, stages of engagement are built on it. And I think that we need to just let this be our guiding point. You know, I speak about evidence-based and making sure the interventions match what's going on. That also applies to early recovery and advanced recovery. You know, like in advanced recovery, when a person's stable and has some sobriety and some abstinence and they're processing and their mind's a little clearer, yes, we can get into more of those process types interventions. In early recovery, when we're strictly trying to set the path and get things started, it is a different approach. You know, I tell everybody all the time, early recovery is largely persuasion, and it really is. Like, we got to sell it, we got to increase buy-in, we got to create a sense of urgency, all the things that like kind of come from my mind. All right, so let me move on. Evidence-based practice is a conscientious problem-solving approach to clinical practice that incorporates the best evidence from well-designed studies directly related to the population the client belongs to, patient values and preferences. It is guided and rooted in the clinician's expertise in making decisions about a patient's care and what the clinician has observed is effective while working with clients. So kind of summarize what I just said. I got a little ahead of myself. The difference between treatment model and a treatment approach is that a treatment model is the process, manner, or framework of treating someone or something holistically based on evidence as a frame of service. So it's like the framework. The model provides this framework. Treatment approach is the act of drawing near, or coming or advancing near, or using a variety of strategies based on evidence, clinician preferences, and therapeutic styles clinicians gravitate towards to. So that's where we're bringing all the pieces in. We're using our natural talents and our trainings and the things that kind of like reached us as an individual to like kind of meet those treatment goals and build rapport and things of that nature. Evidence-based practice or well-supported scientific evidence shows that substance use disorders can be effectively treated with reoccurrence rates no higher than those for other chronic illness such as diabetes and asthma and hypertension. So what we're saying is like addiction can be treatable if we're grounded in the evidence. With comprehensive continuing care, recovery is now an achievable outcome. While supporting scientific evidence shows that behavioral therapies can be effective in treating substance use disorder, most evidence-based behavioral therapies are often implemented with limited fidelity and they're underused. Treatment using these evidence-based practices has shown better results than non-evidence-based treatments in service. And what they're talking about there with the behaviorals is contingency management stuff and early recovery. I know there's research that shows like even having a pool for like you're doing a group and like you have every month you do a drawing for a $10 gift card to somewhere and people with such good evidence get put in the pool, or even unpack it. Like, I mean, if we go a little further, everybody who has 80% attendance for 2 weeks gets a $5 card in the group, or things like that would be contingency management. That's what we're talking about, the behavioral therapies. What research from SAMHSA, NIDA, and American Medical Student Association recommends a typical progression for someone who has a severe substance use disorder might start with 3 to 7 days in a medically managed withdrawal, 28 days in an inpatient facility after detox, or if detox was not needed, they go right to an inpatient. Then after that, 2 to 4 months of intensive rehabilitation care in a residential program, then continuing care, first an intensive outpatient program, or then maybe a 3-day early recovery to a 5-day IOP per week for a few months. That was a little bit of typo there. So I'm saying like based on severity and intensity symptoms, a person might benefit from going right to IOP based on history, or other people might get benefit from going to like a 3-day-a-week group. I know at CASA, we don't have an IOP officially licensed, but our stabilization is kind of modeling that a little bit. I think that with IOP, the requirement's like 9 hours a week, where stabilization might get them like 6. So it's close. You know, I mean, it's the best we can do because it's a different license. Per week for a few months, and later in traditional outpatient program that meets the 1-2 times per week. So again, this is in a general sense, and it definitely applies to how we do it at CASA, but it is speaking holistically, not for CASA specifically. So those groups would be like the PRS and recovery enhancement. For many patients who currently live in situations are not conducive to recovery, outpatient service should be provided in conjunction with recovery support housing as community residents, then supportive living. Regardless of the substance for which an individual seeks treatment or the setting or level of care, all substance use disorder treatment programs are expected to offer an individualized set of evidence-based clinical components. These components are clinical practice that research has shown to be effective in reducing substance use and improving health and functioning. These include behavioral therapies, medication, MAT, and recovery supports, peer services. Treatment programs that offer more of these evidence-based components have the greater likelihood of producing better outcomes. So like, I know we promote family involvement. Family involvement in the research shows that if supportive family members are involved in the process and the collaborative effort and part kind of almost come in as an ally, a part of the treatment team, is a 50% reduction in relapse rates. Same goes with vocational planning. Like I don't remember the number exactly, but it was up there like that. Almost 50, I think about 52, that if there was a vocational part of the treatment plan, that it reduced rates, relapse decreased the prevalence for about 50%. Most substance abuse treatment programs take a multidisciplinary approach that requires a team of people who can help a person heal from addiction. With this approach, treatment begins at intake. It starts with making sure from the start that a person has the right focus on their personalized plan for healing. Working with a team of professionals is the key to healing from addiction, especially in the beginning. Upon arrival at a treatment center, there will be a thorough assessment that puts together a personal evaluation along with vital signs to design the best experience possible. Healing from addiction is a very personal experience for each person. They bring their own challenges to the table, including drug and alcohol addiction histories, trauma, mental health challenges, and physical issues that need support. A multidisciplinary approach begins in medical staff for medical issues. Mental health staff support those conditions and people experience the treatment of co-occurring disorders. Any centered focus on this approach is going to provide a thorough perspective on healing that is necessary to make progress in their recovery. And I think this is perfect time for us, because not only do I feel like I've been with CASA for a while, and I think holistically we try and take this approach and do the best we can, but like we are in the process of officially becoming that place where we're going to be all under one roof. It is an integrated program, mental health. So while we might in-house previously linked to someone with more mental health training, we got a counselor on the hall, LCSW or LMHC, we're definitely going to try to get the client with that and maybe link into it as part of their treatment to a mental health provider. We're going to be able soon to offer all that in-house. So it's kind of an exciting time. Current research and best clinical practice. The most effective treatment programs conceptualize addiction recovery as the developmental process through a series of stages. The core model of most addiction treatment is stage-wise and based in the transtheoretical model stages of change. So that's largely what this is about today. The most effective and evidence-based care is a multidisciplinary approach that brings in medical staff for medical issues, mental health staff to support those conditions, and people experiencing the treatment of co-occurring disorders. Any center focus on this approach is going to provide a thorough perspective of healing that is necessary to progress and recovery. So while always encouraged, the clinician brings their own individual approach, the best practice of an addiction treatment center, as supported by evidence in relation to their model, evidence-based interventions and levels of care. It describes the TTM, Transtheoretical Treatment Model, and the Stages of Change Model with stage-wise interventions to match. That's what this is all about. It is like a treatment model and our framework and guiding point that kind of like bases it on steps and levels and change that the evidence supports to match the person where they are mentally at and where their behaviors and what they're reporting is kind of correlating. Like, that's it in a nutshell. The Transtheoretical model is a motivational enhancement model and provides suggested strategies for public health interventions to address people at various stages of decision-making process. The TTM encourages an assessment of the individual's current stages of change and accounts for relapse in the people's decision-making. So anybody who's familiar with the stage of same, it will say that relapse is part of it. We're going to get into that a little further down the road here. The most effective treatment programs conceptualize addiction recovery as a development process through the series of stages. Long-term recovery from addiction often requires multiple episodes of treatment in order to achieve successful progress through all stages. Blending the philosophy, concept, and skills of motivational interviewing with the theoretical orientation of Transtheoretical model, the stage of change of a core results in clinical framework that allows the practitioner to put in practice a multidisciplinary approach with the stages theory. So what I'm saying there is like, all that other stuff, all that stuff that we're trained to do, and that is great stuff. It's about matching that where it's appropriate. So again, like we got a client homeless and 2 bundles a day and not even think straight survival mode. That's not necessarily the time we're going to use an intervention that kind of unpacks internal processes and tries to get at the core of feeling. We want to get that person stable first. So it's about evidence-based is about matching that stuff we know to where the person's at in their recovery process. And that's what we're talking about today. Think of this as the model of framework we must all work with to meet the common goal of the agency as a whole, recovery. With all the individuality we bring to the table as part of the magic of the work that's done, sort of like the Transtheoretical model enhancement model is our actual toolbox. The strategies, preferences, and approaches that work best for us as a clinician are the tools we keep within it. It's about knowing when to pull those two out. Like just because we have a shiny new hammer, that does not mean that every problem we encounter is a nail. You get what I'm saying there? So we kind of got to like make sure we're getting a screwdriver when we need a screwdriver, or we're getting the level when we need the level, that kind of thing. The stages of change or transtheoretical is a way of describing the process by which people can overcome addiction. The stages of change can be applied to a range of other behaviors that people want to change, but have difficulty doing so, but it is the most recognized for its success in treating people with addiction. The stages of change are the pre-contemplative stage, the contemplative stage, the preparation stage, the action stage, the maintenance stage, and then relapse can be part of its situational and can vary where it shows itself. Most successful self-changers go through stages 3 or 4 times before they make it through the cycle of change without at least one slip. Most will return to the contemplative state of change. Slips, relapse gives us an opportunity to learn from. So I got a short video that kind of unpacks the stages of change a little bit further.
The Transtheoretical model, also known as the stages of change, represents a person's readiness to change. There's 6 stages. These are pre-contemplation, contemplation, preparation, action, maintenance, and relapse and lapse. Today, we'll look at the model in the context of alcohol and other drug use. Identifying where a person might be at in the change process can provide some direction as to how they can best be supported. Let's take a closer look. Pre-contemplation. People in this stage aren't worried about their use. They're not interested in stopping or cutting back. Even though other people might be concerned about their use, for them, the benefits far outweigh the consequences. Contemplation. People in this stage of change still enjoy using. However, maybe they're starting to notice some problems from their use. They're weighing up what changing might mean for them. Preparation. This is when the not so good things about using are starting to outweigh the things they enjoy about it, and they begin preparing to make a change to their use. Action. They've started to make changes to their alcohol or drug use. It will depend on the person's goal, but this might include things like using less or stopping. Maintenance. They're maintaining this change. They've been in the action stage for long enough that change has become easy. They've got this. They're no longer dealing with constant cravings and triggers and have maintained their goal for a significant period. Relapse or lapse. A relapse is a return back to using, and a lapse is a slip-up. A lapse does not automatically lead to a relapse. Both lapses and relapses provide an opportunity for the person to learn more about themselves, what triggers them or challenges them, and what promotes opportunities for growth. It's really important to help the person see any lapse or relapse as a learning opportunity as opposed to a failure. People learn a lot more from their setbacks than from their successes. And that's the stages of change, or as it's known as in technical terms, the Transtheoretical model.
All right, so I am going to go a little deeper in stages of change a little bit further down in this presentation. But for now, I wanted to at least present it and in a way that we could think about it, and not just me saying it, that you can see it's a thing. I'm sure that we've all learned about it at school or in some kind of training, but like that is the core of what we're doing here. And I also, like, the video made me think about, I think that even when I was a clinician, like, lapse and relapse are different, and lapse can be, both can be an opportunity for growth, but lapse can be a little bit quicker thing. Person has a lapse, goes out there, comes in, owns it, accountable. Man, it's horrible. I can't believe that happened. Maybe something horrible happened, and not that that's a good thing, but I mean, like they said, that setbacks are an opportunity for change. I mean, say a person has not used for 8 months and then they have a lapse and maybe overdose, and thank God they're alive and all that, but really that's like an extreme reflection from the universe that you should not go down that road. So there's definitely some talking points and things we can work on. And if a person has insight and can use introspection and see that, it's a powerful thing that can really kind of enhance the recovery process and the therapeutic relationship, you know what I mean? But so it is to not necessarily jump to, just because a person has a lapse or a relapse, that like it's a failure or they did something wrong. Relapse, on the other hand, when they go out there, it's one or two. I mean, if we're early in the recovery process, I would say it's just kind of part of it. Sim situation, someone's got 8 months, they go out hard. We might have to go out and re-engage them. And maybe when we get back started, maybe they were in the action or even maintenance stage, and now we're back in the contemplative stage. We're not starting from square one, but you know, it is a different thing, I guess. That's why I just wanted to point that out. Stages of treatment. So this is different from what the Transtheoretical model is, but goes together, if that makes sense. Stage-wise treatment. I think it's a term that we have all heard, that we are aware of on some level. I'm going to unpack that a little bit further so you can kind of see how the stages of treatment are designed to meet a person where they're at in the stages of change. So the stages of treatment are the guidelines or strategies we should be using and matching interventions to what stages change the client in. There are 4 stages total: the engagement stage, the persuasion stage, active treatment, and relapse prevention. So they're pretty self-explanatory, but I do have a short video in a minute, and then we're going to unpack it a little bit. Engagement, persuasion, active treatment, and relapse prevention. The goal of the clinical staff when working with clients presenting each stage of group is to utilize evidence-based practices and strategies, is to offer the support, matching, and empirically proven interventions. So evidence-based interventions and treatment to assist the client to move into the next stage of change. Because that's what we're doing as clinicians. I mean, like, our early recovery is persuasion. Our goal is to get so we got someone in contemplative. I mean, we are not right in the present working on full abstinence. What we are working on is just getting the person to the preparation stage. That's kind of how that should go. And I know it's easier said than done, but again, this is kind of a framework to think about it. So here I go. I got a little video on the stages of treatment explains.
Research shows that change, or the process of recovering from dual disorders, happens in a step-by-step fashion. This change is an internal process. Initially, people often don't recognize that their substance use is a problem. They are in the pre-contemplation stage. As people become aware that the substance use is a problem, they enter the contemplation stage, where they consider the pros and cons of their substance use and consider the possibility of change. As people decide they would like to change, they enter the preparation stage, where they get committed to change and develop a plan to cut down or stop using substances. The action stage, they attempt to change, and once people have made the change, they continue to use strategies to maintain that change during the maintenance stage of treatment. To facilitate change, clinicians offer different services at different stages of treatment. These stages are engagement, persuasion, active treatment, and relapse prevention. Important components of integrated dual disorder treatment include knowledges about substances themselves, as well as knowledge and skills to provide the different parts of stage-wise treatment. Stage-wise treatment means that clinicians provide different types of services as the client moves through different stages of treatment over time. Clinicians use different skills to treat clients in different stages. In the engagement stage, clinicians use outreach and an active listening style of communication to engage the client into regular meetings and a trusting relationship. They offer practical assistance to help the client establish and work towards healthy goals. In this stage, clinicians begin to assess the client's substance use disorder. Later in this video, we will discuss engagement and assessment strategies and show you examples of several types of assessments. Treatment planning may occur in this and later stages. You can read about treatment planning in your workbook. In the persuasion stage, clinicians help clients explore the impact of substance use on their attempts to work towards their own personal goals. Because clinicians educate clients about the effect of substances, it's really important for you to learn a little bit about the effects of all the major substances of abuse, and you can read about these in your workbook. During this and later stages of treatment, motivational interviewing, a style of counseling that helps clients become motivated to change, is quite effective. In this video, we will discuss motivational counseling and refer you to other sources for demonstrations of this type of counseling. In the active treatment stage, clinicians use substance abuse counseling to help clients learn the skills to cut back and stop using substances. Clinicians teach clients the skills to manage cues or triggers to use without using. We will discuss these skills and show you examples of clinicians doing substance abuse counseling. Medications to treat the substance use disorder can be helpful in this stage, as can self-help groups and family involvement. You can read about these forms of help in your workbook and in the other references listed in the back of your workbook. In the relapse prevention stage of treatment, clinicians help clients develop a relapse prevention plan, and they also continue to use substance abuse counseling and continue to help clients learn and use skills they can use to manage their mental illness and their substance use disorder over the rest of their lifetime. Many clients use self-help groups during this stage of treatment. You will see an example of relapse prevention planning in this video, and you can read about relapse prevention planning as well as self-help in the workbook.
We do not have a workbook. Actually, I'm sure we do if you look around your program. All right, so in the engagement stage, it's basically around the pre-contemplative stage of change, maybe some early contemplative stage. So either the person's completely just not there yet, doesn't know the negative effects or doesn't want to look at, maybe better said, the negative effects of substance use is having on their lives. That's when the client does not see a professional on a regular basis and has no working relationship with a professional. So I want you to think about the engagement stage, and I'm going to go a little further into that. But like CASA itself, we have engagement stage strategies, but we got to utilize them when it's time to utilize them. And what I mean by that is we have now the CCBHC case managers, where they are pre-treatment whole program is for them. Like their goal is to engage people and go out in the communities and meet people where they're at and trying to get services they need and develop a working relationship with clients between them and the agency as a whole. And I say that because even though the CCBHC case manager might not necessarily be fully part of the whole treatment process, once the person gets started, they are our initial salesmen, if you will. They are the first front face. They're the ones that are showing, hey, we're on your team, we're here to help. A honey worker, that would be another engagement strategy. And honey's more with active treatment, they pair more, but if a client slips up and goes back out there, then honey workers are going to be part of the team. Peer services, huge engagement strategy. And I think even the peers, like clinicians, they too have different levels of intervention, because engagement, they might be going out and knocking on doors and trying to get people into inpatient and things like that, where working with a client further down the recovery process, they're doing groups with them and they're meeting individually, you know what I mean? So like clinician, kind of, they have a dual purpose. In the persuasion stage, contemplative or preparation stage, the client has a working alliance professional, but is not convinced that substance abuse is a problem. So we're talking about like at CASA specifically or anywhere, intensive outpatient, stabilization, maybe ERS is still persuasion. A lot of times ERS is still persuasion stage. I think I'll go a little further into it. The difference between stabilization and ERS would be like basically the severity of use and how much harm it's going to cause. Because I think we all know ERS. I mean, we got someone 200 hours worth of crack cocaine daily or a bundle of heroin a daily, and they're using, and we're trying to get them inpatient, and they're not necessarily buying in. We might put them in stabilization, where maybe they don't end up needing inpatient. They get MAT, they stop the cocaine and heroin use, but now they're smoking weed a few times a week. We're going to put them in ERS. So it's not necessarily totally abstinence or ERS. ERS was definitely part of that persuasion stage, but where that more of the preparation stage, I would say, for ERS. During the active treatment stage, preparation action stage, the client is motivated to work on substance abuse and has greatly minimized or discontinued use. In the relapse prevention stage, action or maintenance, the client has stopped using substances or experienced no consequences from substance use for a significant period of time. There are 4 stages of groups that are based on the amount of support a client needs: stabilization, IOP. Again, like, you know, we work with what we got. Pre-contemplative stage, and then is the pre-contemplative stage of change, and then engagement stage of treatment. Stabilization is the highest level of group of support a client receives. They are offered in an outpatient setting as an intensive outpatient or daily groups. They are largely persuasion-based materials such as discrepancy building, working through ambivalence, rolling resistance, identifying increase in motivation, recognizing potential harm of continuing use, and et cetera. Embedded programs too. Embedded programs, I know, like I worked inpatient. If you've seen on my other trainings, you probably heard me mention it at least one time because it was a valuable time in my career. I mean, I feel like I even tried to convince higher ups that we should train everybody there because that's the only equivalent I can give it is the emergency room for addiction, and the opportunity to gain experience and see such a variance of symptoms and mental health disorders and all that is just there. So if you ever get the opportunity, I highly encourage it. If it's after leaving there, I know that my strengths as a clinician have just surpassed even what I ever expected. In the better programs such as detox, inpatient, or intensive residential program considered stabilization service groups, there should also be large and motivational enhancement and persuasion material aimed at increasing client buy-in and participation. What I'm saying is they're just like the stabilization or IOP, inpatient and intensive residential, it is very early in the recovery process. Clients might not be fully buying in yet. Like, so while there's other components of it, persuasion and motivation to get them to the preparation action stage is a big part of the group curriculum and the clinicians' goals working individually. The main goal of stabilization services, by services, I mean like the IOP or the embedded programs, is to make the treatment as accessible and attainable by offering as much as possible. The expectation of client is not abstinence, it's more in a harm reduction. Harm reduction is a big part of engagement stage. I mean, it could take a while, and then even to get, I think we're not there yet as per the regs or per services offered, we're getting close. So harm reduction can go like a layer deeper even before like more community-based going in after a person. This is kind of harm reduction model, but initial steps of towards recovery that we have engaged the client, but it's still like, again, so we're not expecting abstinence. We're not expecting perfect attendance. You know, I think people think about our stabilization group the wrong way about that. Like, yes, that is the goal to move out and show that a person has moved into the preparation action stage to go to ERS. But initially it's about just creating every opportunity possible that the client can walk in that door and get some help. You know what I'm saying? So it's about availability, if that makes sense. The expectation of a treatment is to wrap the client in a metaphorical hug through supports and availability needed to move the client into the contemplative and sometimes preparation stage of change. The readiness to move to the next stage of change will be identified when the client begins to engage in change talk, show a diminishing frequency of use, and if stable stage perverted in outpatient, tends about 80% of the groups. So you're seeing behaviors that match with what we're working on, and maybe the client's reporting, like even before you see the behaviors match, you might hear talk about it. So it's like the client starts to say that like, hey, maybe I need to do this. Hey, I can see how this impacted me here, da, 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 da. And then you start seeing an improvement in behaviors that suggest that they are working towards what they're saying. It kind of like, you know, there's an old saying, I like believe half of what you see and none of what you hear. I mean, that's a little excessive, but I think it applies here a little bit. So anybody can talk the talk. This is when a person starts, and it's very early. Maybe they're walking a walk or even crawling. They'll try and getting ready to walk. You know what I mean? But that's when we start to know that it's time for a client to move on. It can also be marked by successful completion of inpatient intensive residential programs. So like, again, the vetted programs with that higher levels of clinical care, they are an engagement strategy, very early recovery strategy. But if a client sticks through and finishes it, like that says a lot. You know what I mean? That definitely shows that there is at least some buy-in there, that if they're willing to stay in a place for 28 days, or maybe they did inpatient and 3 months residential program, that's huge. You know what I mean? It doesn't necessarily, you got to be careful because inside a structured setting is different, but someone just did 4 months in an embedded program, you know, even if they were mandated to, like, it still says a lot. You know what I mean? Because trust me when I can tell you, a lot of people mandated, even with prison hanging over their head, doesn't necessarily mean they're going to complete and they will leave AMA. So for a person to do that, it's not everything, and it can vary. So like I said, it's something you got to be careful. Some people that might not be full buy-in, but maybe just were a little motivated by extrinsic things like treatment court or parole or probation finishes, and then someone who kind of was didn't have heavy lumen, maybe charges pending or self-referral. It doesn't necessarily mean they're different because, again, like you just never know, but it is something. Just because they finish that doesn't mean that they're like recovery rock stars. I mean, they're definitely something worth noticing, recognizing, affirming, but I think you still need to start at the beginning stages of treatment. They're not like all in yet until they demonstrate that out in the real world, I guess. You know what I mean? To clarify, if a client is to stabilize an outpatient setting where the client demonstrates a diminished frequency, intensity, and severity of use that has the potential to cause serious harm or death, no longer using heroin, but still using cannabis for 30 days, or has no use whatsoever, 2 weeks, for 2 weeks, and at least 80% of attendance of appointment rates can be considered stable. So again, doesn't necessarily mean a person's like, woohoo, I love recovery, but they're definitely stable. And they're at a point that they're safe to be supported in an outpatient setting. And that's kind of what those services are about. They're about engagement, they're about availability, and they're about observation of us as the professional to see what's working, what's not working, and what we can do to help. You know what I mean? And the contemplative or even preparation stage of change, and then they're moved to the active recovery stage. And that's why I said ERS, even though still like geared towards persuasion, preparation, early action, it is the active stage of treatment where vetted services and IOPs and stabilization services are not necessarily part of that active. They're, while we're doing active, it's active treatment stuff in some things, we're given skills and we're using clinical skills. They're past the point that we community engage, so the ball is rolling. It's still more of an engagement stage of treatment. Active recovery groups can be further broken down to 3 categories based on the stage of change a client is in and the level of support they needed. So I already talked about early recovery a lot. Advanced recovery, it's PRS with us. Relapse prevention, it's recovery enhancement with us. So again, and CASA is not unique in this. I've worked at 2 other agencies previously. I have contact with a lot of agencies. Every agency that I know about is built off this transtheoretical model, stage of treatment and stages of group, and it's designed to follow progression. And I think we all know it. I just think we get away from it sometimes. So my purpose of my day is to remind you what our core is and what the CASA agency mission is and what the evidence supports to kind of, this is our guiding point. Again, with the toolbox metaphor, this is our toolbox. All the other stuff is the tools we keep within it. It is important to note the transtheoretical model is widely utilized, and although groups may differ in name, mostly all outpatient program designers instruct in this way. So these ones, early recovery skills, 3 times a week, contemplated preparation stage at match, again, active part of active treatment, advanced PRS I put in here, 2 times a week, action stage of treatment. And I think that's another one too. And I'll talk about that in a second. Relapse prevention, typically 1 time a week. And it's, even though we call it relapse prevention, and then when someone might leave us, they're still kind of early remission. So you're still in the action stage of change. You know what I mean? You don't want to minimize the progress because it's huge, but I'm just saying for us as clinicians to be aware of. And I want to talk about the groups for a minute because it is my personal peeve. And I know I'm not alone. I talk to other colleagues, like, say we got a client that actively using, we're trying to engage. It is okay to be creative. It's okay to think outside the box. It's okay to tailor when appropriate. Not always, because then we're minimizing. If we're just, I do a training on person-centered care that you'll watch a little bit, like it is a negotiation and a collaboration. So, I'm not saying that, but if we got a client and they're using daily and we're trying to engage and they don't want to go 5 days a week, even though we know that stabilization group doesn't require 5 days a week. So we should be trying, I don't think we should tell them directly that we don't expect it, but like, it's definitely something we could throw out there. They don't want to go 3 times a week. So we think it's a good idea that we put them in PRS for 2 times a week. I think that's flawed thinking. And I say that for a couple things. A, it's going to minimize the progress everybody else in that PRS or the recovery. Maybe it's a one-time a week thing. So same kind of thinking I see clinicians do. It's going to minimize the progress everybody in those advanced recovery groups have made. They're in there talking about they ain't used in a month and a half. And this guy is reporting they used yesterday or this morning. There's going to be some feelings around that. And it's going to minimize kind of what it means to be in that group for the other participants. You dig what I'm saying? On the flip side of that too, or maybe point B, but better said, if we're really being evidence-based and following these interventions, stage-wise treatment and matching our groups in one, the curriculum is not going to match that client. Do you understand what I'm saying? Like if we got someone that is in active use, contemplative, pre-contemplative stage, and we're trying to just be creative, which is a beautiful thing. I'll unpack a little further in a second as possible suggestions. Then that's great. But now we have them in a group that's all about things they're not ready to hear yet, like meetings and emotional coping and trauma that we might be working on, trauma issues and things that are relevant and they're going to need to get there. But right now they ain't ready to hear any of that. They're trying to they don't even think they have a problem and this shit doesn't even apply to them. Excuse my language. So again, it is very important to match the stages of group with the stages of treatment and the stages of change. And that is the core guiding principles of what we're doing here today. So I do have another group. They talk about the stages, another video. They talk about the stages of group. After that, I think I have, let me check here. One more slide after the video. I think I will cut that then. We're going to be about an hour and then I'll do another video. I unpack the stages of change a little bit further and talk about some other things. So let's watch that video. We'll talk about the last slide and we'll end this one today and I'll start the next.
People often wonder why we think group therapy is an ideal form of counseling for people with dual disorders. Well, people use substances in a social context, so it makes sense to treat the substance use disorder in a social context as well. The group provides an opportunity for social support, peer feedback, and modeling of skills to get sober. Additionally, group treatments are more economical than individual treatment. Several different types of groups can be helpful to clients with dual disorders. We recommend you set up 2 separate groups, an engagement stage group for clients who are still using substances and aren't yet ready to quit, and an active treatment group for clients who have started to cut back and are ready to quit or who have already quit using substances and are in the relapse prevention stage of treatment. Self-help groups are useful to some clients who are in the active treatment or relapse prevention stage. Not all clients benefit from self-help. Those who are very symptomatic or those who just don't want to go should not be forced to go. To learn more about how to use self-help groups, you can read the section in the workbook. Social skills training groups are also helpful for dual disorder clients to learn the skills necessary to make sober friends and to deal with people in high-risk situations. The high-risk situations could be drug dealers or friends who continue to encourage clients to use substances. You can learn more about how to conduct social skills training groups by reading a social skills training manual, such as the one written by Kim Muser. In this video, we will discuss dual disorder groups in more detail and then show examples of groups. A dual disorder group for clients who are in the engagement or persuasion stage of treatment is set up to be attractive and helpful to these clients. The group is brief, supportive, and educational. The purpose of this group is to help clients learn about the impact of substance use on their lives and to examine the pros and cons of their substance use in a supportive environment. To ensure that the persuasion dual disorder group is attractive to clients, the leaders provide refreshments and a schedule of fun activities such as drawings for prizes. The leader briefly checks in with each client and then leads a brief interactive discussion about substances or other topics of interest. Although members are not expected to be clean and sober, nor to attend the group regularly, the rules and norms of the group are made clear. They include confidentiality, regular check-in, and no intoxication or disruptive behavior during the group. The group is co-led by 2 people so that a co-leader can help a disruptive client leave the group or help a client in crisis if needed. Topics for discussion in persuasion groups include personal and family history in the form of a genogram, discussion of personal experiences of substance use, sometimes referred to as war stories, decision balances, social skills training, coping skills training, and health information. The leaders use simple printed materials to help clients learn about the topic of the day. Guest speakers liven up the group and make it more interesting for members. Active treatment groups are for clients who are trying to cut down or stop using substances. Group leaders expect these clients to be more motivated and to attend the group regularly. These groups focus on education and skills building. The leaders use cognitive behavioral techniques to help clients cope with the cues or triggers to use without using. Leaders of active treatment groups encourage more peer interaction than in the engagement groups. They are very supportive, and the leaders actively work to avoid confrontation of group members. These groups meet weekly and are offered in a long-term schedule that allows clients to attend for years if they would like to. The topics of active treatment groups are similar to the topics covered in engagement groups, but are more directly focused on stopping substance use and avoiding relapse. Topics include coping with cues or triggers to use in high-risk situations, managing emotions, coping strategies, relaxation skills, and other ways of coping with stress. The leaders teach clients these and other healthy behaviors, including dealing with infectious diseases such as HIV and hepatitis. Active treatment groups are an ideal forum for clients to learn and practice social skills that they can use to help them stay sober. Helpful skills include starting conversations, maintaining conversations, expressing negative feelings, and refusing offers to drink or drug. Group leaders can help clients find alternative leisure activities and develop cognitive skills for sobriety, such as identifying and challenging self-defeating thoughts. Next, you can watch a segment of an active treatment group where a group member discusses her recent relapse. Notice how the group leader uses reflective listening skills in this group. Also notice how he elicits feedback and support from other group members. He asks the other group members to describe similar experiences, and he educates the group about relapse and relapse prevention. And specifically, he talks about how to keep a slip from turning into a relapse. Note that he may have had a different topic to focus on for the day, but since the client came in describing her slip, he took that as an opportunity to support her and focus on relapse.
You wanted to share before we got into any of the topic.
Right.
And that's fine. As you know, when something comes up that you want to talk about that it's affected your recovery, that's an important thing. So go ahead.
Well, group, I had relapsed 3 weeks ago. What happened was I went to a friend's funeral, a very close friend of mine. And I went by myself. I didn't have any support with me. My mom was busy. She had to go to a training at her job, and I didn't have nobody else to go with me, and I took it harder than I thought I was going to take it. I thought I was going to be able to go and be all right, but once I seen them in the casket, it just hit me so hard. It took me for a loop, so I went out and got a bottle afterwards, and that started me up. I drank for 3 days.
So you drank for 3 days straight after that?
Yes. And I came up here, I don't know why I came up here drunk. It beats me. I don't know what I thought I was doing. And my friend said, I said some things to her, my best friend, that hurted her feelings. And Dr. Dekoff said I was in her office, and I have no memory of being in her office. I thought it was going to ease my pain that I was going through, because it really hurted my heart, you know.
So you were looking to get rid of the pain at that time with the
Right.
alcohol.
Right.
What happened when you were drinking then? Did it help?
No, it made things worse. It made me think about him more.
Mm-hmm.
I can remember sitting on a bridge telling myself my life wasn't worth nothing. I wanted to just jump over, but I was a coward. Couldn't do it.
So things got bad for you,
Yeah,
to the point where you felt like ending your life.
yeah.
Let me ask you, is that what brought you back? Was
Probably
at that point? As people are listening to what Joyce is talking about, you're sharing some very painful things that you've gone through. People, recently, we've been talking about different stages of recovery. People have an idea of what Joyce was going through at that time.
I do. Yeah. When I first started crossover, I was suicidal myself. And plus, I was suicidal and homicidal. I thought the world was coming down on me, didn't understand me. I felt like nobody liked me. I thought I was ugly. And I thought people was talking about me behind my back. You know, but I don't think you was a coward when you was trying to contemplate suicide. I think you here now, and I think what you did is more courageous than ever because you brought yourself back in the rooms. And plus, you explained to everybody how you feel. If you kept it bottled up, it could have been worse. So.
You know, he was one of my support system, in my support system. But no, he was really good to me, really good to me. You
Sounds
know,
like he was a true friend.
Yeah, I miss him a lot. I still, just like it was yesterday, I be thinking, you know. But I guess he in a better place than here. One day I hope to see him again.
You know, and I'll tell you what you're sharing. The issue of losing somebody who's so important to you. And I know that you and I have spent some time talking about how important he is to you, that he's somebody who supports your recovery. He's been with you a long time.
Right.
And loss can be...
Over 30 years.
Over 30 years. So it is a lot to lose. And it's not uncommon for people to have a loss to reach out to a bottle or a drug or something like that. Let me ask that in terms of the group members, have you ever had a loss which led to that urge or that craving or that desire to use?
I guess I'm the only one. I guess I'm the only one.
I'm not sure. It could be that other people are struggling with kind of talking about some of the experiences. Bringing up loss is a painful thing. It's a painful process. And coming in and sharing about what you've been through is an important piece. I do want to bring up something that Ray had said. He talked about you being courageous to come back in.
I was embarrassed when my friend told me how I was acting. I said, I don't know how I'm going to face him again. That's what my thoughts was. I said, I better switch to Harvard Hospital somewhere.
You didn't have to come and face us.
Yeah.
So how was it facing us now?
Well, I was a little bit anxious when I first came in last week. I was like, And then I said, Bump, that's where I go for treatment, and I'm going to keep on going there. I'm not going to let that stop me. Because I talked about it with my counselor over at Blue Hills. And she said, you know what, you're not the only one. So, you know, she said, and they know it was the alcohol, it wasn't you. So that kind of made me, you know, have more confidence to come back, you know. After me and her talk, and me and Charlene talked, she came over there and, you know, we talked.
Good. So your clinician came over there and met with you at Blue Hills?
Yeah.
Good. Actually, you bring up one of the things that often keeps people who relapse active in their relapse. When you're talking about kind of a feeling of shame, in a sense. You don't want to face people. You don't want to come back and say, you know, I had that slip, or I said those things that I said that I didn't mean. Those things are expected. I do want to ask other people in the group if they had that experience. Can you remember back to a time that you had a relapse? Who here in this group has had a relapse? Just a show of hands. Ever? Ever? Yeah.
This is the conclusion of the Evidence-Based Practice Integrated Treatment of Co-Occurring Disorders video. We're grateful for the help of the many members of the Implementation Resource Kit team, as well as the clients, clinicians, and other people at the Mental Health Center of Greater Manchester and the Hartford Capital Region Mental Health Center for all their help with this tape series.
All right, stages of group explain and how they fit the stages of change in statements of treatment. Watching that video, I've seen it a few times and I like it very much. I think it's a little old, I see, but it's still good stuff. And it's still what we are doing here as a treatment agency and what recovery looks like and what client progress looks like. And I think that's the thing right there that we need to be aware of. I mean, ethically, we are bound to like monitor outcomes and make sure what we're doing is effective. We work in a subjective field, so sometimes that can be hard. And sometimes like progress looks different for people and progress might be defined different for different people. You know what I mean? But that doesn't mean that we should deviate from this model, this evidence-based model that we're talking of today, because it is about outcomes. It's about client behavior and it's about outcomes that lets us know when it's time to move on, to move up, to whatever. You know, you get what I'm saying there? And by client behavior and what they're talking, the client talking, what they're saying, matching what they're doing. And that's the stuff that leads to the outcomes, because the outcomes are urine screens are an outcome measure, whether it be abstinence or at least a reduction of use. Client might still be positive for cannabis, but has not been positive for heroin in 2 weeks. That's progress. Client attendance is progress. Client, and that's an outcome. Clients agreeing to go inpatient, residential program. Those are all outcome based and what we should be working towards, especially in the early stage. You know what I'm saying? Now we get into advanced recovery and active, the outcomes stay the same, but now it's more about clients maintaining the behavior and outcomes might look a little different. Outcomes might be they got a job, they went back to school, they whatever, they got an apartment. I mean, like someone engages and works inpatient, residential, community residence, and then they got an apartment, independent living or water supportive living. Those are outcomes. And those are the things that we know support recovery and our evidence base, and the stages of change, stages of treatment, and stages of group are part of that. Those are kind of what we're putting in the mix, the guiding principles, if you will. You get what I'm saying here? So again, all that other stuff that we do is very relevant and it's important, and keep doing it, but don't lose sight of this. That's the take home message today. Like I told you, I did the CASAC application for 350 hours. Oasis is still core in this as well. You know what I mean? So even though we know all these other things, we take a training, DBT, all of a sudden everything we're looking at becomes a DBT issue. I didn't do it on purpose, but as I said it, I'm going to end with that. And because I am going to take the last slide as an opener, even though I'm going to record the second part today, you might not take it today. So I just want to do it as I'll use it to refresh everybody and kind of get the juices flowing. But before I close, I'm going to bring it back. Marsha Linhan, if you did not know, she created DBT. She opened up our training today talking about the importance of evidence-based. And even though she's a creator of a well-respected and renowned model, she wasn't saying just use DBT. She was saying match what is needed to what we know works, and there's a need for it in the field. So that's the take-home message closing today. I'll see you when you take the next one, or maybe in person. Everybody have a good day.